Go for it.
All right. Hello, everyone. My name is Dr. Alexander Lister. I am a podiatric surgeon, and I'm just going to give a talk about, going from community college onto podiatric surgery. And I'll go through my background. I'll talk a little bit about myself. I'll talk a little bit about why I chose podiatry. I'll talk a little bit about school, residency, fellowships, if that's what you're interested in. And then we'll talk about my career. I'll show you a few pictures from patients, and we'll go from there. So I currently work at a foot and ankle center in Sacramento called Sacramento Foot and Ankle Center. That's my email address if anyone wants to email me if you have questions or concerns, or if you're even interested in podiatry, but we'll get started. So what is a podiatrist? A podiatrist is a doctor of podiatric medicine, known also as a podiatric physician or surgeon, qualified by their education and training to diagnose and treat conditions affecting the foot, ankle, and related structures of the leg. So podiatry is quite interesting in the sense that, depending on what location you are throughout the United States, or even if you're in Canada or in Europe, you'll do different things, or you'll be licensed to do different things. And in the state of California, in the United States, we're licensed to do surgery, and then all other foot and ankle related issues. If you go on YouTube and see like the toe bro, I think he's in Canada. And I think his training doesn't have a surgical component. So you'll see a lot of ingrown toenails and procedures that they're doing in the office. But based off of what I do over in California, United States, I see pretty much everything related to the foot. We see dermatological issues in the upper left side. We see pediatrics with congenital deformities like clubfoot. We see fractures of the foot and ankle, and then we also see vascular issues and or wound care, which is sorry, go ahead.
Did you share your screen, by the way?
Oh, I didn't. Oh, my
No.
bad.
Yeah, I think you didn't share the screen.
Oh, well, hold on. How do I do this? You should have stopped it.
I know. I was like, I know you're showing pictures, but I'm not seeing it.
Wait, where is it? Let's see.
If you go to the middle, it says share screen, and then it lets you pick the screen if you're using multiple monitors.
Oh, I'm only using one monitor. I've never done this before, right?
It's in the middle. Do you see it says share screen? It's a green button.
Oh, there we go. Desktop, share screen. Okay. Well, thanks for letting me know, because I got pictures up here and I'm like,
Oh, he hung up.
things that we cover. This is different pictures of what we cover in podiatry. So, like I was saying before, upper left side is, dermatological issues. Anytime a patient comes in the office, they're like, oh, this is on my foot. I'm expected to at least have some idea of what's going on and how I can, treat this. On the lower left-hand side, that's a clubfoot pediatric case. So, again, kids with foot issues, they come in the middle section, you see a fracture right there. And we treat that all the time. And then wounds or bad blood flow. And all of these pictures kind of sort of show how, and we'll dive deep into what I do and then how I interact with other services as well. So, pathway to success. There are 9 podiatry schools in the United States. There are 2 in California, 1 in Arizona, 1 in Iowa, 1 in Ohio, 1 in Chicago or right outside of Chicago, 1 in New York, 1 in Philadelphia, and then 1 in Florida, here in Miami. So if you ever want to spend 4 years in Miami, go to podiatry school. But all of these educations, they're the same. They're all, you take pretty much all the same courses. You go through, your general education of the of the foot and lower extremity, and you learn the rest of the body. One misnomer about podiatry is that you just focus on the foot. And I had a professor who always says you can't treat the foot without knowing the rest of the body. So I went to one of the schools in California, Western University College of Podiatric Medicine. And then after that, you do a residency, which is 3 years. There's actually 1 or 2 residencies that are actually 4 years over in New York. And that's just for extra training. And if you decide to, you can do a fellowship. Most of the fellowships are surgical, but there are 2 research fellowships in the United States that you can do. And one of the research fellowships is affiliated with Penn State. So it's a really good program, heavily researched. So again, those are the colleges of podiatric medicine. I highlighted the ones that are in California, just in case anyone's interested in being in California. But again, I mean, the education is the same. You know, these committees get together and make sure that there's a standard of focusing on the lower extremity, but also focusing on the rest of the body. Residency programs. So again, there are 282 currently. That's actually increased since I applied to podiatric medical school. I think one of my biggest worries was that at the time there was a residency shortage. There were too many applicants trying to get into residency than they had spots. But again, that's changed completely since 2012 when I applied. And so there are 2 types of residencies. There's a PMSR, which is just forefoot related. And when I say forefoot, I just mean the toes in the middle of the foot. And then there's PMSR, rear foot, reconstructive rear foot, and ankle surgery. And that's when, you know, you're trained to focus on the forefoot, the rear foot, so the heel, and then also the ankle. So again, ankle fractures, heel fractures, you know, midfoot fractures, toe fractures, metatarsal fractures, anything related to the foot and ankle, you are trained to treat, and you will be trained well to treat. Fellowship. So a fellowship in terms of podiatry is an extra year of training, and different fellowships focus on different things. So there are some fellowships, and most of the fellowships are focused on reconstructive surgery. So if you decide to do a fellowship, you're going to be doing a lot of heel fractures, you're going to be doing a lot of ankle fractures, you're going to be doing a lot of external fixation devices, you're going to be dealing with a lot of dislocations of the lower extremity. And then there are other programs that focus on diabetic wound care. So, you know, if patients come in with wounds and you're trying to save their limb, you'll focus on that. But it gets pretty heavy into the advanced treatment of the foot and ankle. So, you know, even if you're doing flaps in terms of plastic surgery, you'll probably learn a lot of that in those in that year that you spend, and you're just doing a whole lot of foot and ankle stuff. And then in terms of the research fellowships, they're heavily into research. So in terms of podiatry, we focus a lot of research on diabetic foot care, simply because we are pretty much the only ones who really focus on diabetic foot care that we're all trained to do. You know, if you're a vascular surgeon or orthopedic surgeon, you probably deal with wounds, but for the most part, if you're an orthopedic surgeon, you deal with a lot of bones and a lot of hip fractures and fractures all across the body. If you're a vascular surgeon, you're dealing with, you know, blood flow issues. If people have, you know, dead tissue and they need to restore their blood flow, you'll deal with that. Vascular surgeons, they're busy doing those things. And we as podiatrists happen to get a lot of foot wounds. So career choices, typically, for the most part, you can kind of do almost whatever you want. So for example, you can work at an institution, you can work for a hospital, and there's in Sacramento specifically, there's, you know, Kaiser Permanente, so you can be hired by them. You can work at the VA, be hired as a podiatrist. You can work at Sutter. There's the Dignity Health System here, and you would be hired by those people, and you would do pretty much everything related to the lower extremity. They're all pretty much well-rounded in terms of fractures, wounds, nail issues, dermatological issues, things of that sort. And then also you can join a podiatry group. So typically there are groups throughout the United States that consist of, 2, 3, 4, 5 podiatrists who just focus on the foot and ankle. And they can kind of specify if they want to specify in things, or they can focus on general foot issues. So, for example, I'm at Sacramento Foot and Ankle, and I've kind of navigated more towards wound care. So I see a lot of diabetic foot wounds. I mean, every single day I'm dealing with a foot wound for a patient. And I have my partner, he doesn't want to do any foot wounds. He just wants to do trauma and fracture. So he sees a fracture every day. He's reducing an ankle dislocation pretty much every day. And probably 2 to 3 times a week, he's doing heavy surgeries in terms of trauma. And then I have another gentleman in our group who's just doing outpatient care. So he'll deal with hammer toes, bunions, things that aren't emergencies, but things that are causing people pain, and he can fix surgically. And then I have some people who in our group who don't do any surgery. They just deal with routine foot care. So they trim nails for patients. They get rid of ingrown toenails. If people have warts, they deal with them. And their schedules are pretty cool. They work a 9 to 5, and they kind of go from there. Also, you can join an orthopedic group and focus on the lower extremity. Again, a lot of these podiatrists who are working in these orthopedic groups are fellowship trained. So again, they've had advanced training in the foot and ankle. And they're the people who treat it. They'll do ankle fusions. So if you have arthritis in your ankle, they'll do ankle replacements, things of that sort. In the larger cases, the reconstructive surgery cases. Okay, so let's talk a little bit about my path. So I'm from Sacramento, California. I grew up in a neighborhood called Antelope near Roseville, if no one's aware of the Sacramento area. I knew I wanted to be a doctor. The main reason why I wanted to be a doctor when I was a kid is because I wanted a Lamborghini. And then I found out anesthesiologists made a lot of money. And so I wanted to become an anesthesiologist. And I just told everyone that, not knowing what they did. I just said, hey, I want to be an anesthesiologist. It's a lot of school. I think I can be successful at it. And that was my thought process. And so after high school, I went to American River College. I didn't know what school I wanted to go to. So I said, I'll go to junior college. And I took science classes. I'll be honest, I don't think I was as serious as I should have been. And I think that's where mentorship comes in. You probably want to be around someone who's going to kind of give you a real world explanation of what you're doing. And I think I struggled a little bit in my courses, but I kind of made up for it. I spent 2 years there, and I actually transferred to UCLA. And I wasn't a science major. I was an African American studies major because that's what I was interested in. And I met people who said, hey, if you are interested in something, go for it. And you can take those science classes, which worked out for me because I really enjoyed my time in school, and I was able to take those science courses, some of the science courses. But again, as we know, undergraduate school is very expensive. So I finished UCLA in 2 years, and I actually decided to come back to Sacramento and take some courses at junior college, actually. But moving back a little bit, when I was at UCLA, that's when I was first introduced to podiatry. So the gentleman on your left, his name is Dr. Robert Blaine. He's actually the father of my roommate when I was at UCLA. And it was funny because our first interaction, my roommate was like, hey, Dad, this is Alexander. He wants to be a doctor. And his first thing he said to me was, oh, like, do you want to be a foot doctor? And I said, I don't think so. Like, that's not my interest. And he was like, oh, interesting. And he proceeded to tell me that there were not a lot of Black foot doctors. And I told him, I was like, I think it's because Black people don't want to touch feet. And I was dead serious. I was like, I don't want to be a foot doctor. Like, I don't want to touch feet. I don't want to be around feet. I want to do something else. I didn't know what I wanted to do, but I knew I didn't want to touch feet. And he was like, okay. And he was a nice guy. And he was like, well, if you're ever interested in podiatry or, working on the feet, we don't just play with feet or trim nails. We do a lot. And he was a really nice guy. And he said, if you're ever interested again, I can show you around and, we can talk about it and you can shadow me. And I was like, that's cool. Like, it was really nice and refreshing for, a doctor to just say, hey, yeah, if you're interested, I'll, just let me know and I'll make an effort. And so moving forward, I finished up at UCLA. I kept in contact with my roommate and Dr. Blaine. But again, I still wasn't truly convinced. And so when I got back, I ended up going to American River and Sierra. Actually, I took some classes at American River and Sierra just because I think it was a little more challenging to get all my classes in one location. But thankfully, I had a really good support system in my parents who let me move back home and take courses. So then at that time, I ended up taking, I think I took a physics class at AR and then biology over at Sierra. But I was introduced to AMSA, ARC, and I met a bunch of wonderful people there. And I joined, and that was in 2011, 2012. I was the vice president of outreach. And that was really my gateway into figuring out what it is I wanted to do, because I was able to join the, now they call UC Davis Pre-Health Conference, but I think when I was doing it, or when I was a part of it, it was the AMSA ARC UCD Pre-Health Conference. And I actually had met another podiatrist there, going back to the gentleman in the middle. His name is Dr. Lawrence Harkless. He was he is a podiatrist, and he was telling me he was opening up a school, and his job was to tell everyone about podiatry. He was an extremely nice guy, and literally the first time I met him, he was like, hey, if you ever want to be a podiatrist, come on down to SoCal. You can come stay with me. You can stay at my house. And I was just kind of blown away, like, whoa, this is the second nice podiatrist I've met. And he was a really cool person. We had some good experiences together, and he told me a lot about podiatry even before I applied to school. And then at the time, interesting enough, I had an ingrown toenail, and I met the third podiatrist over at Sutter in downtown Sacramento. And I remember interacting with him, and he was like, hey, you have ingrown toenail. And he was like, hey, you want to be a doctor? And I was like, yeah, like I met these two podiatrists who are great. I'm thinking about it, but I don't know if I want to do it. And he was like, you should do it. It'll be great. And he was like, what questions do you have? And during my, encounter while he was fixing my toenail, he's telling me about podiatry. And he's like, hey, next week I'm doing a surgery. Like, we'll get you signed up to come in with me. Like, you can shadow me. And he was just like, you're going to be a podiatrist. And I think at that point I was like, okay, I'm about 80% sure I want to be a podiatrist. And also at the time I was doing the UC Davis pre-surgical internship. And I think it was every Wednesday we'd wake up early in the morning and we'd go shadow different surgical services at UC Davis. And I realized at that point I liked surgery. But none of those fields really caught my eye the way podiatry did. So I decided to apply. I applied to two of the California schools. There was the Samuel Merritt School and there was Western University, which I did not get into Samuel Merritt. They told me my MCAT score wasn't high enough and to do their summer program, and I could go the next year. And I applied at Western. It was all in the same week. And Western said, hey, yeah, come on down. We're accepting you. You'll be a great foot doctor. And I was really kind of torn between whether I wanted to stay closer to Northern California or go back to Southern California. Mostly because my family's here. And again, I had a girlfriend, which is now wife at the time. But I was like, hey, I want to be a doctor. Like, that's my job. Like, that's what I want to do. So I ended up going to SoCal and I spent 4 years there. and I met some really great people, my two really close friends who I text with daily. And then after that, I went back up to Northern California and I did my residency training at the VA Palo Alto. And again, that was a great experience. It's affiliated with Stanford. So again, a lot of my rotations were at Stanford. And it was, and actually I did a lot of rotations over at Kaiser in San Jose as well, but we'll get into that a little bit more. So Western, pretty much all of these schools are about the same, but just in terms of, schooling, you take their first 2 years are just, you focus on the whole body and you supplement your classes with lower extremity. So, the first semester you're taking anatomy, biochemistry, pharmacology, and, these teachers aren't just saying, hey, focus on the foot. They're, asking you questions about the brainstem. They're asking you anatomy questions about the back. They're asking you, what nerve is this in the lumbosacral plexus, They're asking you questions that any doctor should know. So I would never tell any of you to think that, if you go to podiatry school, it's just a lower extremity 4 years. It's not. It's the lower extremity. It's pharmacology. It's neurology, emergency medicine, things of that sort. But all the while you're focusing on lower extremity courses throughout those 4 years. So you're learning about, different pathology of the lower extremity. You're learning about the anatomy of the nail while you're learning about, the cranial nerves. And then you get into systems your second year at Western. So again, I take a cardiovascular system where, I have exams and I'm reading EKGs. I don't read EKGs, but I'm pretty good at reading an EKG just because of the training. And you're learning about the respiratory system, endocrinology, and you're learning about the entire body. And those are the first 2 years. And then after your first 2 years, you end up taking your boards to become a licensed podiatric physician in the United States. We take 3 boards, and I'll go back around and talk about that. But in your third and fourth year, you're doing externships. So you're at hospitals. So you're at a hospital going through different rotations. And again, it's not just podiatry rotations. It's heavily based on podiatry. But again, I'm in an office with the endocrinologist learning about diabetes and interviewing patients. Actually, my first patient I ever saw was at the VA. It was a respiratory clinic, and this gentleman had COPD. And I just remember, I'll never forget him because he was the first patient I interviewed. But again, it wasn't foot focused. It was focused on this guy's breathing and his respiratory issues. And you obviously do internal medicine where, patients are inpatient and you're managing them. You're looking at their labs, you're running tests, you're treating their pneumonia and things of that sort. And again, you're being supervised because you're still a medical student, but these are patients that you work with, and these are patients that you try to get better. And then, you continue that, but then into your fourth year, at least at Western, we do things called externships, because those are basically the interviews for residency. We do 8 of those, and you basically go around the country for 1 month each, and you focus and you learn about their program and you see if you like it. And if you want to, you apply. And if you don't, you don't. So I did, I believe I did 8. I did, Cedars-Sinai in Los Angeles. I did the VA Palo Alto, which is where I ended up. I did Kaiser Santa Clara. I did the VA in New Mexico. So I was in Albuquerque for a month. I did a program called St. Elizabeth in Boston. So I spent a month in Boston. I spent a month at the University of Louisville doing an externship. And then I was also in Texas, in Fort Worth doing externship. So it's quite the experience to spend a month in each location and kind of go from there. And then after that, you pick your residency. So I ended up again at the VA Palo Alto. In my program, and every program is pretty much like this. You may have a few different things here and there, but I pretty much spend at least 2 weeks to a month on each rotation. And then you focus heavily on podiatry because that's what you're going to be. But For the most part, my first year I was doing internal medicine for a month. And again, you're a resident, and these doctors or these attendings don't expect you to say, "Hey, I'm a podiatrist. I only focus on the foot." They say, "No, you're a resident. So go treat this patient for pneumonia." And again, this was before COVID. So, you're in the wards, you're staying late, you're staying overnight, you're managing patients. If your patient has an issue, you get the page. It's not you're attending. Um, and then so, you do different services. I did psychiatry, infectious disease, and it's not just the diseases that are affiliated with yourself. You're affiliated with all diseases. So on that rotation, I was seeing patients who we were working up for HIV or, different types of severe infections. I remember I had a patient who had fungal pneumonia in the ICU I was managing, and you learn how to treat the body. And that's why it's so important to, focus on your education. And while you're in school, not just focus on the lower extremity, you have to learn the entire body. Again, vascular surgery, orthopedic trauma. So, during that time of my training, I did 3 months of orthopedic trauma, and I was doing hip fractures. I was putting rods in hips. And I was fixing ankles, and I was fixing knees, and I was fixing clavicles, and I was fixing shoulders. And you learn that, the human body, fracture is a fracture is a fracture. And if you can take those principles into your own private practice when you're out in the field, you'll never forget those things, and you'll have a well-rounded experience. I was in the ER reducing different types of fractures, or in the ER running codes. Again, I don't do those things now, but you need to know how to treat people. General surgery, plastic surgery. I don't have that on there, but we did major plastic surgery cases, which take 10-12 hours. Doing free flaps, or you're literally taking one part of the body and putting it in another part of the body and making sure the blood supply is adequate. You literally spend all day in the operating room doing that with the attending. And then private practice. So we, as podiatrists, we are heavily into private practice. So we would spend a lot of time with practitioners who are in their private practice. And then outpatient surgery, which is, again, your non-urgent surgery. So hammer toes that are curling, or bunions on your big toe that is deviating. We do surgeries to fix those things. So again, it was a well-rounded residency program. And pretty much most or all residencies in the United States will give you a well-rounded experience, so you can come out an adequate and well-trained physician. So this is the group I'm with, Sacramento Foot and Ankle. And again, there are a bunch of us guys, and we're getting larger and larger, but different people do different things. Me and, two of the other guys, we do a lot of wound care, and we're on call at hospitals, and they call us for wound care. Some of these guys don't do any surgery and don't deal with hospitals, just, work from 9 to 5 and finish their notes and go home. And again, see a lot of things that, are outpatient procedures, but they don't have to go into the hospital for those things. And then there's one of the gentlemen here who does a lot of foot and ankle fractures, and he just really likes to do it. And there are a lot of people who fracture their body parts, especially their foot and ankle, and it'll keep you busy if that's what you want to do. All of us do office procedures. So again, we'll cast for insoles, people who have flat feet. We'll treat ingrown toenails. We'll do a bunch of routine care. So older patients, you get a lot of older patients who can't trim their nails, and it's very gratifying actually to do that for people, and they're very thankful for the things that you do, and you build relationships with these people. All right, so now I'm going to talk a little bit about a few of the cases that I'll present to you guys. So again, so I'm on call at 2 different hospitals. And basically what we get called for is wound care. Most hospitals you'll go to, they have orthopedic trauma, orthopedists on call. So they deal with a lot of, the ankle fractures if they want to. They'll deal with foot fractures if they want to, or they'll call you. So most hospitals will say, hey, we have someone dealing with fractures. We don't have anyone dealing with wound care. And thankfully for me, that's just what I enjoy. So, I'm on call right now, actually, but I'll get, a call and someone will say, hey, this person has a wound. How can you help them? Especially, and it's specific to the lower extremity, because that's what I treat. So this 30-year-old lady came into the hospital and she told me that her friend's friend bit, or her friend's friend's dog bit her. And she said, it hurt like crazy. And, I went to the ER the first time, a different ER. They just cleaned it out, but then it ended up looking green and nasty. And I came here and they called you, and now you're here. And actually, the picture on the left was after the first surgery. So she basically had kind of loose skin and subcutaneous tissue and muscle just kind of hanging out. And it looked really bad. It looked green. It looked like there was bacteria growing in there. And so I set her up for an incision and drainage. And so basically, I make an incision around there and I look for pus. I look for things that show signs of infection and I remove it. Luckily, she's 30 years old and it's on her leg. And, typically young people can heal pretty well. So once you get rid of infection and, put them on antibiotics and try to make sure any bacteria that's in there is gone, they tend to heal well. So I ended up cleaning it out. Surprisingly, she didn't have much feeling. She said, it had hurt when it initially happened, but after that, it stopped hurting as much. And I think it's because the bite was so deep, it went to her nerves. And so I cleaned everything out and I put actually a stem cell graft on there. And stem cell grafts are one of the things that we use as podiatrists to help wounds heal a little bit faster. And so I did that. And actually, she got discharged from the hospital. She was on antibiotics. And then I saw her for her post-op and it actually was green again. So there was more infection. And I was like, oh, crap. And it wasn't deep, thankfully, and it wasn't going up her leg or down to her foot. So I sent her back to the hospital and did another procedure. And I put a wound vac on her foot. Basically, a wound vac is when you use suction and negative pressure to fill in a void. And so I ended up doing that, and it's good for treating, wounds, and it leaves them open. And if patients can handle it, they do pretty well. So the picture on the left was right after I actually took off the wound vac, and it looked really clean and healthy. And that may look a little nasty to you, but as a podiatrist, that looks really clean. And then you just do local wound care. You put things on it to keep the area clean and dry and rid of infection. And it slowly over time, it fills in, and it fills in the middle picture after it continued to fill in. The picture on the right as it continued to fill in. And then she ended up disappearing for a month. And then she saw me this week and it was all healed. So again, these pictures show kind of, and I don't have dates for them, but they show like, the chronicity of the wounds and how it's not just a initial, hey, I see you first for one time and then you go off on about your business. I think I first saw her in August and that wound was healed by last week. So quite a bit amount of time and effort. But again, when you see this person who's 30 years old who has this giant bite and this chunk of tissue taken out of them, you want to do what you can to help them. And she ended up healing. Most of my patients aren't that young, and I have older patients. So this gentleman was a 79-year-old male, and actually he had got this wound on his leg, his right leg, because he was going to a nursing facility and he fell transferring. I think they were trying to transfer him and he was kind of stingy and was like, I can do it myself. And he tried to do it himself and he fell and he hit his leg and he scraped his leg. And he was seeing his primary care doctor and she was just putting Neosporin on his leg, not knowing how deep it was. And so I saw him in the hospital and I was digging around and I was like, hey man, this is a really deep wound. We have to get rid of it. And actually I had just started out in private practice. And thankfully, one of the doctors was on call with me. So we did the surgery together. And I remember being in the operating room and thinking, whoa, like this is a really deep wound. And he was like, yeah, it is deep. Yeah. And we went through the case together. Um, and it turned out pretty well. So the picture on the left was actually after we had cleaned it out. We got rid of the edges that were dead and dying, and we started him again on a wound vac, which uses negative pressure to fill in a void because he had a large void, and that's a large wound. I think that wound was around 15 centimeters long and around 7 centimeters wide. So it's a large void to fill in. And so, we started the process. He stabilized, he went to a nursing facility, he had dressing changes regularly. I ended up putting, again, a stem cell graft on him to speed up the healing. And I think that second picture is pretty much when we started using the stem cells. And that yellow stuff on there is the stem cells, like after about a week or so. And then this is how he continued to heal. So over time, again, that void filled in, and you can see the borders of where the actual wound is. But it started to fill in, and it continued to fill in, and he's done well. And actually, he lives outside of California, and I haven't seen him in a while. But he sends cards or emails and says, "Hey, I'm doing well. Like the wound hasn't opened, and he's doing great." All right. And this is actually one of my partners, a fracture that he did. So it was a 41-year-old female, large female, and she fell and her foot stayed one way, her foot and ankle stayed way, and the rest of her body rotated. So she had this fracture, and it's a spiral fracture of the fibula and the tibia. So the two bones in your foot that connect, or in your leg that connect to your ankle. So this is a pretty big case, and it's pretty much piecing Humpty Dumpty back together again. These plates are pretty big; they're pretty extensive, and those cases are pretty challenging to bring things back together, to realize or find which bone part goes where, how you would fixate it, to where it doesn't fail. Again, if the patient accidentally starts walking on it, or by the time they start walking on it, you have to build a construct back that's going to give them the stability to be able to walk again. And if you can see around her leg, she has a pretty big leg, so she was a fairly large woman. But the case turned out well. My co-worker did a great job, to be honest. So that's kind of how these fractures looks. And again, every fracture is different. That's a fracture that was closed, so the bone didn't break through the skin. And you can have these open fractures too, as well, where you're dealing with, bacterial infection that you're trying to get rid of. And you're also trying to fixate these bones back together. So one day, hopefully this person will walk again. And nails. So I spent a decent amount of time doing nail care at nursing homes, because lots of people go to nursing homes and their feet are neglected and they're there for other reasons and no one looks at their toes. So I got a call for this guy who hadn't had his nails trimmed in probably around 5 years. He had psychological issues, so he never really, checked on his feet, and no one ever checked on his feet. And I'm sure he was probably homeless at one point. And so I went in and I had my nail clipper, and I had been trimming nails for 7 years at the time from school and residency, but I had never seen anyone's nails like that ever in my life. So I asked him if I could take a picture, and he said sure. And so those were his nails, and I trimmed them. And he was just wearing socks all the time. He wasn't even wearing shoes, wasn't even wearing sandals, and he wasn't wearing it because it hurt. And those nails looked like they were extremely painful, and he has a fungal component of that too. So again, it's not always about doing surgery and doing bigger cases. It's when you see patients like this who need help, you help them, and they're extremely grateful for that. I have much more patients who I trim their nails And 5 minutes later, they're like, oh, thank God for you. Like my foot feels so great. And that's rewarding. Even if you started out as a young person who never wanted to touch feet, you see the difference it makes in people's lives. Something so simple, and it really helps them. And then you have people who, again, going back to your training, where, you're not just learning about the foot, you're learning about systems, and you're learning about people, and you're learning about the psychiatry of people. This gentleman, actually, I had been seeing off and on for about a year. He actually never came to my clinic. He was just always in the hospital, back and forth. So he had psychological issues, and I don't think he had the support or family to help him. And he ended up losing half of his foot, but that's kind of where the story begins. He lost half of his foot, and he kept leaving board and care homes. He kept leaving nursing facilities and would just be on the streets. And he would not take care of his foot. So it progressed. So ultimately, he had infection in his toes, and they took off his toes. And actually, if you're looking at that foot, it looks really good, especially on the top. There's no true signs of infection. It just looks like a foot that's kind of swollen. But again, you'll see he has infection. I'll go to his X-rays. The actual X-ray on the left is his foot before any sort of surgery he's had. He actually had an infection, and it's probably hard to see, but he had a wound under his fourth metatarsal phalangeal joint that went down to his bone, and there was pus coming out, and the infection spread throughout a soft tissue to where they had to remove half of his foot. Now, the X-ray on the right is actually after half of his foot was removed, but he started to have a wound, and he never followed up with anyone. And the bacteria basically started to eat away at his bones and his foot. So we'll go to this picture. This is the infection he has. And I remember seeing him for the first time, and that X-ray correlates to his actual foot. So that X-ray is real time based off of how his foot looks. And I remember telling him, hey, if you don't take care of this foot, you're going to lose your leg. And he was like, okay. And I was like, we got to do surgery to clean this out. And he said, no, don't touch me. I don't want you to touch my foot. And I said, hey, you're risking losing your limb. Your infection could spread and you could eventually die. And he said, that's okay. I just don't want anyone to touch my foot anymore. And I said, okay. And he was treated with antibiotics. He was sent to a nursing facility. He was discharged, or he actually might have left because he didn't like the food there. And he progressed. So that was his wound the second time I saw him. And that's the X-ray that correlates. So if you go back to this X-ray, he still has some bone on his forefoot, at the tip of his foot, and on the outside of his foot, but it's starting to erode. And if you see, it looks like half of his foot is actually kind of gone. Even though that soft tissue is there, there's so much infection in there that it's eating away at his bone. And again, same story. I saw him. I said, hey, I can't even save your foot now. You have to lose your leg. And he said, no one is taking my leg. We will continue antibiotics. And again, as a practitioner, you try to do what's best for patients, but sometimes they don't want to have those things done for them. But again, he got antibiotics again. He actually stayed in the nursing home for the whole time this time. But again, that infection in that foot, based off of where the bone looks and where the actual wound looks, there's no way that would heal. There's no way that he would have a functional foot. And as soon as that wound healed, he would be walking on a bag of bones. So to avoid that, we recommend him having a below knee amputation. So that's amputation right below the knee. If you feel your kneecap a little bit below there, you perform an amputation, and people do fairly well with prosthesis, fake legs. And so this was the last time I saw him, around a week ago, and this was his foot. So if you look at the X-ray, his whole foot has eroded. He has those bones there, and it's literally just floating in his foot. And if you look at his foot, his wound on the bottom actually healed, but he doesn't really have a foot. And if you look back at the initial surgery, which was this, he has not had a surgery since that point. His foot has just eroded because of the bone infection. And this gentleman is a very good example of why we end up doing amputations and why in school you're supposed to learn about the entire body, even the psychological aspect of people, because that can happen to you. It's very unlikely that it would happen to anyone. But again, he refuses any sort of amputation. He's been in the hospital a few times, and he just doesn't want it. And he has capacity to say no. So meaning psychiatrists say he understands the repercussions of not having this procedure, and he understands that it could be the death of him, but he's willing to take that chance.
So they didn't try to 5150 him.
So I think they tried a few times. But again, the psychiatrist said he had capacity. So that's a different story for a different time. But yeah, that gentleman, yeah, that's his foot currently. And so these are some ingrown toenails. Those are just, standard. People have parts of their nails that are digging into the corner of their skin, and it causes inflammation, and there's bacteria in our feet, and you get bacteria in that area, and then it starts to become red and inflamed, and you have pus coming out. And that's almost, the picture on the left is almost how my foot looked when I first met that podiatrist who introduced me and let me go into the operating room with him. I was playing basketball a lot at the time, and if any of you have played basketball, which I'm sure all of you have, you do a lot of stopping and going, and your toes tend to hit your shoes a lot. And that can, if your nails are too long, it can cause an ingrown toenail. So I see lots of adults with ingrown toenails. I see lots of kids with ingrown toenails. That's typically how they present. The good part about it is after I numb that foot up and I get rid of part of that nail that's causing that issue, they tend to do fairly well. They typically don't even need antibiotics. They just heal well and they feel better. And that's one of the good things I like about podiatry. Every single day I see a patient and I can do something for at least one of them to where they walk out of my office feeling pretty good about themselves. And then so this gentleman was quite interesting. Really nice gentleman who had a wound on his feet. He actually had very bad blood flow, meaning that the arteries from his heart to his feet were just clogged. He wasn't a smoker. He just was diabetic and hadn't really taken care of himself. And interestingly enough, when I saw him for these wounds, he didn't even know he was diabetic. He just said, "Doctor, I can't really feel my feet and I have these wounds and they're not getting any better." And so again, I worked him up. He was in the hospital and he found out he was diabetic. And I told him, "Hey, we're going to give this a fighting chance." So we started to do wound care on him, local wound care. I saw him regularly in my office every week. And, for someone like that who had just found out they were diabetic and they were at risk of losing parts of their body, you definitely want to give them a chance. I have patients who know they're diabetic and who aren't taking care of themselves. And, they know they're leading a life towards amputation. And sometimes they're even willing to do an amputation before it even gets to the point where I think they need an amputation. But sometimes you get patients who just don't really know what's going on. They haven't been to the doctor in a while. And unfortunately, this is how they kind of present in your office. So I told him, if you can control your blood sugars, if you can take care of yourself, if you have a good support system, which he did, I said, "Hey, we can try to save this, even if it's uphill battle." And he ended up coming into my office, and you can't really tell because he's an African American gentleman, but has a lot of redness in his forefoot, and I actually started to see pus over where his baby toe was and his fourth toe was. And I said, "Hey, we got to get you to the hospital. This isn't working. We got to try to do what we can." And unfortunately, he had a severe enough infection to where he ended up having amputation of the fifth toe, the fourth toe, and then the metatarsals, the knuckle bones behind them. But it got rid of the infection. And this is what his X-ray looked like. So he's missing the fourth toe and part of the metatarsal, the fifth toe and part of the metatarsal, and that's how the wound looked after surgery. And so there wasn't enough tissue to stitch that together, so I did not try, especially with someone who has poor blood flow, because when you're pulling tissue, it'll start to strangulate the tissue. So again, I started wound care on him. And this was the last time I saw him in the hospital. And then 2 weeks later, I saw him in the office after a wound vac, and that's how the foot looked. So that void filled in a lot. He's bleeding well, even though he has poor circulation. He had a vascular procedure done to open up the arteries to his foot. And he started to heal. And I'll stop and talk a little bit about the relationship we have with different people in the hospital. As a podiatrist, as someone who focuses on wound care, you're going to work very close with vascular surgeons, because most of the time when people have a cut or a scrape or something on their foot or hand or wherever the case may be, you'll heal because you have good circulation and blood flow brings nutrients to your body to allow it to heal. When you're diabetic, that is not necessarily diabetic, but when you have bad blood flow, whether you've smoked, a lot of the times when you're diabetic, that blood flow is decreased. And so it takes a longer time for wounds to heal. And you have a wound that has, dead tissue on it and it's infected. A lot of the times it's because they don't have great circulation. And you have to have your vascular surgeon go in and open up some arteries or do a bypass procedure to restore that flow, because going back to this foot and this foot, even if I get rid of infection, if he doesn't have good blood flow to his foot, there's no way that that's going to heal. There's just no way. There's nothing that I can do to that foot to restore blood flow and to bring those nutrients to allow that foot to heal. So you're dealing with multiple services and you're trying to get people involved who do know what they're doing so they can help treat this patient. And that's the job of physicians, to treat patients. So he had a vascular procedure. I got rid of the infection. We started a wound vac, and then it started to heal up. And that was, I want to say, a month later. So he just literally has a scab over his foot. And he's actually doing great now. He's doing a really good job. He's walking, he's working, he's doing whatever he needs to do, and he's controlling his blood sugars to where I don't think he's on very many medications, and he's traveling the world and he's living his life. So he's done very well for himself. And I'm thankful that I was a part of the journey to help him. And with all my patients, they're extremely appreciative of the things that we do. Yeah, and now that was the last slide. And so now if anyone has any questions, comments, concerns, complaints, anything like that, we can kind of go from there.
Yeah, so I basically, anybody could unmute themselves and ask your question. I figured that this is a small enough group and kind of want to keep it free flowing instead of.
Yep.
So ask any questions you have, just unmute yourself and.
Okay, so hi, I'm Noemi Moreno, and I'm a student at Moore Park College over in Moore, California, and I am a treasurer of the pre-med club. So I was hoping, I really enjoyed this meeting with you, and I was hoping that maybe one day we can schedule an appointment so that you can talk to all the pre-med students at Moore Park, whenever you're free.
Yeah, absolutely. Of course. Yeah, I know.
Awesome. Good. Can you share your email, or maybe I'll put mine here because I know that
it's in the chat.
Yeah, I just put it in there in the chat.
Okay, thank you so much.
Yeah, absolutely.
I'll go ahead and do an email. Thank you.
Yeah,
really
of course.
Meeting.
Absolutely.
You're doing great.
I think I'm going to ask myself some questions. Just kidding. I'm not going to ask myself questions.
Anyone else have any other questions? Anyone? I have one. What did you do to study for the MCAT?
Oh my gosh. Do you remember this story?
Yeah.
I was actually going through my emails and I was like, yeah, yeah. All right. So thankfully through the was it UC Davis pre-medical conference, Mr. Afshar was offering if we well, I don't know if it was if we were in leadership or if we just
Don't go through that. Just do what you
oh,
studied for that.
oh.
How did you study? Not how did you got the course, but how did you?
So actually I took the Kaplan course. I took the Kaplan MCAT course. It's so interesting because I have no clue what the MCAT is like now. I suspect Kaplan is still doing courses, but pretty much for the MCAT, I took the course. I basically had to shut everyone out in my life, my family, everyone. And I just started to grind. And actually that's pretty indicative of what med school is. When you're taking the MCAT, you are studying your butt off for an exam that can pretty much make or break you. You know, if you're not a good test taker, you have to become a good test taker. If you're not diligent in your studying, you have to become diligent in studying because you're not supposed to be able to go into the MCAT and just ace it off of, you know, not studying or not doing very much. And that's what med school is like, you know, all of my courses, they're extremely challenging. They're hard, you know, they're not easy courses. They make you think, they make you reach out to different people. If you've never had a tutor, you'll probably get a tutor. You'll ask your classmates, you'll ask your roommates, you'll get frustrated. But that's a part of becoming a doctor. That whole process of the MCAT is kind of where it starts because, again, you're studying for the MCAT. You don't know, you know, specifically what questions there are going to be. You are just, you know, trying to learn these principles and you're trying to do repetitive studying constantly. And hopefully you do well. And then, you know, you go to med school and it's the same thing. You're learning all these concepts. You don't know what's going to be on the tests. The questions are going to be hard. You don't know what the questions are going to be, but you're hopefully learning these concepts and drilling down these concepts. And you're, you know, in a situation where if you've always been able to memorize things in med school, you can't, because ultimately you're learning concepts. You're not learning how to take or answer specific questions, because questions will have multiple concepts within them. And that's what real life is. You know, no patient comes into my office and, well, maybe a patient or two will come into my office and say exactly what they want and exactly what they need. But for the most part, most patients come into my office and they're like, "Doc, my foot hurts." Literally, that's the thing they say. My foot hurts. It hurts when I walk. And I have to figure out which bone is hurting, where it's hurting, if it's just an ingrown toenail, if it's they, you know, broke their leg a year ago and now they have flat feet. Like, you have to figure those things out. And that's kind of where it starts with the MCAT. Again, they're tough questions. It's a journey. It's a process. But if you go through it, if you choose to go through it, or if you even if you decide to get into healthcare, it's extremely rewarding. Extremely rewarding.
What about the challenges of like when you were in, what are some of the study techniques or wisdom that you have for being successful in either undergrad or med school?
If I'm being honest, I think undergrad was probably a lot of memorization. I think even at AR versus Sierra versus UCLA, was a lot of memorization. It was just looking in a book, figuring out what questions they're going to ask and learning the questions. And filling out, you know, doing your worksheets and, you know, if you're in statistics, running through a bunch of different statistics questions to where you can kind of sort of see similarities on the test versus the actual studying. But I think that's what undergrad teaches you. It teaches you how to complete a task. It teaches you to go from point A to B. When you get to med school, you learn how to think. So for example, for me, I was taking those classes, but from the time I graduated from UCLA, it was 2011. And when I entered med school was 2013. And even after I'd taken classes, I took a year off and just worked. So by the time I got to Western, I hadn't studied in a while, and I was like, oh, this is going to be really hard, so I might as well enjoy my summer. And I didn't know how to study anymore. Like I didn't. And I realized the first day, you know, they're throwing all these concepts at you within an hour, and you're like, there's no way I can memorize this. Like I just can't. Like there's absolutely no way. And thankfully, my roommate was kind of extremely OCD in the sense of he would just like sit at his desk from sun up to sundown when we didn't have school. Like Saturday morning, you wake up at 7 and he wouldn't stop studying till like 8 p.m. He was just like drilling these concepts down, you know? And I was still kind of thinking I could just breeze through and kind of sort of figure things out. And when I was like, I struggled through my first test. And I remember he did well. I remember I was like, oh my gosh, that was so hard. And he was like, dude, that was so easy. Um, and then so I remember I started studying with him and I was like, hey, how do you figure this out? And basically what he would do is he would literally listen to the lectures and he would ask himself questions. He would say, and then he would just kind of go down this rabbit hole of these concepts. And he would say to himself, well, why is this? Why does this make sense? Like, this doesn't make sense. And so he would start, you know, studying it that way. And he learned lots of concepts. And so when the test came, he never studied test questions, but he knew these concepts because he was always asking himself questions. And that's actually what I started to do. And it kind of freaked me out because I'm like, I'm just used to memorizing questions and I'm used to studying questions. And once I started learning concepts, the questions became easy because, again, like I said, in med school, one question will test 2 to 3 different concepts. It's not just from point A to B. It's the question is A, and you have to go from A to B to C to get the answer. And again, that relates to medicine in general. None of my patients are just, hey, doc, my foot hurts. Do this, you know? And that's kind of how I took my approach to studying. And that's how I take my approach to patient care as well.
How much studying do you do now?
It depends. I'll study. Depends. If I have a surgery coming up, I always study. I mean, that's just me because I don't want to go into any situation not knowing much. Or if it's a surgery I haven't done in a while, I'll do a lot of studying. I'm a little bit more of a visual learner, so I will print things out, or I'll watch a lot of videos too. I'm not an auditory learner. I just can't listen to something or remember it. So in terms of studying, I still do study a lot. I still read a lot of journal articles because medicine is always changing. And even just from, 2012 when I was in school to the way that I practice now is different. The podiatrist I was learning from at that time, I think that they probably aren't doing some of the things that I'm doing now because medicine is just changing and you learn what works and you learn what doesn't work and you learn what works for your practice. For example, I think when I was in school, there was pretty much 1 or 2 ways to treat fungus on nails. Now there are a bunch of ways. Just kind of depends on your patient and what they're interested in and what they want to try and how much money it costs. But again, in 2012, it was we try this or it doesn't work at all. And now it's like I got 5 different things that I can try with the patient. So again, even in 9 years, medicine has changed so much. So
Does another question. Tell me what your typical day or week is as a podiatrist.
Good question. So for me, again, I do a lot of wound care. So I'm heavy in the wound care grade. Okay. I'll give you an example, 3 examples. One example is me, my week as a wound care specialist. Another one is the gentleman who does most outpatient surgeries, and the other is one of the guys who does mostly just no surgeries. So for me, typically, if I'm on call on the weekend, then I just go to the hospital whenever I'm needed. So that'll be typically, it's never really extremely late. So sometimes I'll be at the hospital maybe till 9 if I'm waiting for a surgery to go. Sometimes probably as late as 10 or 11, but for the most part, that's few and far between. But I'll usually be there until around like 9, weekdays and weekends, no matter when it is. But throughout the week, I'm in a clinic. So Monday through Friday, I'm just in the office. And then through lunchtime, sometimes I'll go to the hospital to see patients that I have in the hospital. And then after my clinic, I'll do surgeries at the hospital. Sometimes I don't have an afternoon clinic. So sometimes my clinic will be in the morning from 9 to 12. Then I'll take a lunch. And then from 1 until 5, I'll go to the hospital and I'll see patients who may be in the hospital. Or I'll do a surgery that's scheduled to be done, or a surgery that's an emergency that just needs to be added on to the surgical schedule. That's typically my schedule. My schedule is a little bit more hectic because, again, with wound care, patients don't just say, hey, I have a foot wound, I'll be at the hospital on Tuesday at 3 p.m. They just say, oh, I looked down, I had an infection, I saw pus, I came to the hospital. And so I have to be a little bit more available to see those patients. Now, the gentleman who just does outpatient surgery, he'll do surgeries typically on, say, a Thursday. So every Thursday, he'll do 3 or 4 or 5 cases. The rest of the week, he'll end up doing clinic. And then, he'll have his post-op patients throughout the week, right? So that's typically his schedule. Sometimes he'll take call for wound care. So maybe once every 6 weeks, he'll be in the hospital on the weekend. But for the most part, it's a pretty standard 9 to 5 with logistics and filling out paperwork and doing all of those things you have to do as a physician. Now the gentleman who does no surgery, it's just 9 to 5. So he goes in at 9, sees his patients, types up his notes, goes home, goes to his family. And again, I would like to let you guys know that these things are kind of interchangeable. So at least for me, I'm in a good group to where I think if I don't want to take call, if I don't want to do wound care anymore, I could probably switch. I could just stop taking call and start doing something else. Or if the gentleman who isn't doing surgeries, he can start taking call, because again, we're all trained to do surgery. There aren't any residencies within the United States that will train you to not do surgery. And as long as you are licensed to do surgery, and as long as you keep up on your boards, you can do surgery. So yeah.
Very cool. Do you guys have any other questions? Anyone? No one?
I sent one in the Q&A. It's pretty long, but I was just interested about the patient that you talked about that refused to get his leg amputated, and it just gotten worse and worse. And
yeah.
I guess if you can talk more about, I guess, like your experience with it, how it changed your perspective, and how it made you feel, and I guess like if the 5150 plan, how did it went, or I know very little about it. I know it's like
so 5150 is a term that's actually it's a police term that's used, and it's basically a physician can put someone and a police officer, which that could be easily overwritten by a physician, but basically means that someone who is unable to care for themselves and is a harm to themselves or another. So for 72 hours, when that order is placed, that person cannot make any decisions. And basically, And you do it in a lot of psych patients or people that are having psychiatric emergencies. Now, granted, it's a very regulated thing. Like a doctor can't just go in there and say, "I'm going to put you in a 5150," and that's it. There is like a whole process, and then usually, smart doctors get a psychiatrist to co-sign on it because the psychiatrist could sit down and do an interview and say, "Okay, is this patient competent?" And in a sense, I mean, you have constitutional rights to deny care. It's just if you're doing it because you're altered or your mental status is not there, you're bipolar, all these different things. And so, and I'm sorry to bring up that term. We use it a lot in the ER because the people that we see are in crisis, and a lot of
Yeah.
times you place that on there. So, um, in terms of the what Dr. Lister practices is also, I mean, he has that ability to put that on there, but you have to be very
Yeah.
judicious to do it. It's not just like, well, you know what, it's not that easily that you say, you know what, you're going to 5150 and do whatever you want to them. There's like a lot of documentation and things.
Yeah. So typically what I do when I have patients like that, so I guess let's backtrack. So as a podiatrist, I'm consulted on things. So typically, if a patient has an issue, and they go to the hospital, they'll be seen by the ER doc. And if they're admitted into the hospital, they'll be admitted by the hospitalist. So basically the gatekeeper who manages their care. And then they will say, "Oh, hey, you have a foot wound. Let's call the podiatrist." So they'll call me in, and then I come in and I see them and I assess them and I say whether they should have surgery or whether they don't need surgery, an acute surgery. So in the hospital, everything is deemed acute. So if someone comes into the hospital and they're like, "Hey, I have a bunion," that's not an acute procedure. So I say, "Hey, come see me in the office." Going back to that gentleman, so I was consulted on him because he had a wound and it was a chronic wound. And I went to go see him and I talked to him. And throughout the conversation, he was well aware of what was going on. So for that, basically he wasn't having any psychiatric crisis. He wasn't saying, "Hey, don't touch my foot because there are aliens who are putting bacteria into my foot and it's causing an issue." Right. So something like grandiose or if he was saying someone's talking to us and they're telling me not to do anything to my foot. So he wasn't having any sort of, psychiatric crisis. He just didn't want to have his foot cut off. And I remember having the conversation with him to say, "Hey, you know that this infection can spread and it can spread up your leg and it can spread into your blood. And you can end up with bacteria in your blood, which can seed into your heart and you can die." And he said, "Yes, I'm well aware of that." And said, "I don't want to have a foot amputation." And based off of those things, it's kind of interesting because one of my really good friends, he's a psychiatrist. He's a forensic psychiatrist. So he deals a lot with capacity. More so in his realm is mostly with people in prison. So if they, commit a crime, he determines whether they were aware of what they were doing. So me and him have a lot of conversations on capacity because I deal with patients like this a lot. And he always says if the patient is aware of what's going on and they're aware of the consequences and the repercussions of that, and they can, look beyond just their hospital stay and say, "Hey, yeah, I could potentially be without a leg, or I could potentially lose my life, or any of these things," and they have an understanding of that, then it's very hard for a psychiatrist to say, "Okay, this patient doesn't have capacity and doesn't know the ramifications of what you would be doing to them." But when, there's a psychiatric crisis and there's an emergency which comes to the lower extremity, that's a whole different ballgame, right? So if someone's like, they have a severe infection in their foot and there's a bunch of pus coming out, and I'm like, "Hey, this has to come off tonight." And he's like, "No, because if you take it off, then, the aliens are going to take me to Mercury and this and that." And he's, deemed, and he's been diagnosed as bipolar and he hasn't been taking his medications. then they're typically 5150'd, and then I'll either talk with a family member, typically, and I'll get consent through them, or if they have a power of attorney, I'll get consent through them. But typically, it's very challenging, or it's very complex, and a lot of things, a lot of steps you have to take to actually perform any sort of procedure on someone who doesn't want it, and they have capacity. So how that made me feel, probably a little frustrated, more so frustrated because, again, as a practitioner, it's your job to help people, and we don't take our jobs lightly. I don't walk into a room and say, hey, this needs to come off, I'm going to take this off. I assess the situation. I listen to the patient. I listen to their social situation. I listen to if they have care at home. I listen to if they're homeless. I listen to, if they've gone through this before, or if they know someone who's had an amputation. And I take my time and I explain it to people, because it's not a small thing. Having a surgery is having a surgery. It's a big deal. And so, I did all of those things, and I talked with him, and it was really interesting too, because that's how I knew he had capacity, because he wasn't eloquent, but he understood everything. And we had this conversation, and he was like, I'm just going to try some antibiotics. I don't want to have this surgery. And he said no. And I was frustrated the first time, because, again, I wanted to help him. And part of being a podiatrist who's African American, I want to help lots of people. And when I see a minority, I see someone who looks like me, I identify with that. I see that person as potentially could have been my uncle. And I would have wanted someone to take their time and talk with him the way that I'm talking with that patient. And so the fact that he was just like, no, I think the first time I was frustrated, but then when he kept coming back, I was just like, okay, like, it's just his choice. It's just what he wants, and ultimately he understands what could happen. And that was the end of it. And so, again, every time he comes into the hospital, I'll see him. I won't say, oh no, I'm not seeing this guy. I'll treat him as best as I can. I'll do what I can. But it's pretty much the same thing. I tell him, hey, your foot is a bag of bones at this point. There's nothing I can bring back. And he's like, oh, I'll just try some antibiotics. And
Yeah, and anytime you want to do surgery on anyone, it's more about them understanding the risks, because it's not 100%. They could
Yep.
stroke out. So they got to live with that decision. So that's why consent is so important. Not so much that, it's not, pardon my French, it's not a pissing match with a patient, but they have to understand the risks and what those risks bring, and they're going to have to live with those consequences as well.
Yep.
My other question is, I think you touched that a little bit, but in your training and both, like, even undergrad, but even podiatry school and residency, you were always the only Black man. How did you manage that? And I know one of the stories, so if you don't want to share that, that's fine. But
Hey, which story?
but
Which one?
we'll
You
talk
tell the
later.
story. You can tell the story. I don't mind.
No, just how you've dealt with being the only, Black person in the room, and how have you?
I would say this. So I think, how do I put this? I think when I was younger, especially like an undergrad, I think it probably bothered me a little bit more. But I think as I got older, I realized I realized there weren't going to be a lot of people that looked like me. And there were going to be challenges. And ultimately, I felt like there were times where I'm like, I have to be really good at this because people are looking at me. And I don't want people to think that, like, oh, affirmative action is what got you here, or any other reason why I was here other than I was an intelligent person. So I think, thankfully, the people I was around were really helpful. And it just so happened that my two really close friends in school, they were minorities too. So one is a Hispanic guy and the other one's a Korean guy. and we just were able to talk with each other about these things. And not saying that any of my classmates were bad. I don't think so. But I think we all knew that there was like almost like a obligation or a little bit of heaviness to be good and to at least try to pave a way for our people. Again, the gentleman who was at the conference, Dr. Harkless, he was a black guy. So it wasn't too hard for me, but I think that I kind of accepted what it was, and I knew there weren't going to be a lot of people that look like me. And it was part of my responsibility to try to do the best I can. And if there are people who look like me who want to get into podiatry or minorities, I guess in general, because podiatry is historically a field that's heavy in white males. I mean, even there's not even a lot of women in the field. It's just mostly white men. So I was more so like, hey, if anyone wants to be a podiatrist, I'm here to help. And I knew that there would be pressures. Actually, and I don't know if this is the story that Jubin or Mr. Afshar is talking about. But I have a tattoo. I have a barcode tattoo on my wrist. And I remember my mom being like, you want to be a doctor? Like, why are you doing this? Like, what's wrong with you? And I remember that was like something that like kind of opened my eyes. And she was like, you know, you're a black man. Like, why do you have a tattoo? Like, people are going to take you seriously. And thankfully times have changed, and I'm in California. So, you know, I see nurses with sleeves. I'm sure Mr. Afshar at Highlands, you see plenty of people with tattoos, all ER docs everywhere. And you know, we've progressed, but yeah, I think that there was a time where I think if it were 20 years ago, I'd probably feel a little bit more apprehensive about the things I did and the way I lived before going to school. But now I'm like, I'm just here to help people. I'm here to help people who want to be podiatrists. I'm here to help people who are interested in podiatry, here to help patients, and go from there.
Very cool. Does anybody have any other questions? Anyone? You could unmute and ask. You could type, or we're just gonna let Dr. Lister go.
I have a question. I don't. This is probably a popular question you probably get, but what kept you motivated throughout this whole journey of yours?
Actually, it was my grandma. Actually, hold on one second, real fast, okay? I'm getting a call. Give me 10 seconds, okay? All right, hold on.
Go for it.
All right, sorry about that. Duty called. Okay. What motivated me? I actually wanted to become a doctor for selfish reasons, but as I progressed, it was my grandma actually. So she was diabetic. She never had any foot wounds, but she went to the podiatrist. She was on dialysis, so she was end-stage renal and saw a nephrologist and had lots of doctors. She actually ended up passing away from a heart attack, but she would go to, when I was younger, I'd go to appointments with her, and she would always tell people, this is my grandson, Alexander, and he wants to be an anesthesiologist. And the people and the nurses, they'd be like, oh, good luck, this, and that. And she actually would go to the hospital that I'm primarily at now all the time. So it's weird going through the corridors and remembering kind of visiting her. But that was more so my motivation. So I told myself, hey, I want to be a doctor. I want to be something that would have helped her. And so that's, again, she never saw a podiatrist, but she had a podiatrist. She really enjoyed him. And so I was like, hey, I'll try this. And that was what kind of motivated me throughout the whole process. I was just like, there are plenty of people who have grandparents, or there are plenty of grandmas out there who need a podiatrist. And I was just like, okay, if I were to ever to quit, I mean, obviously she would have loved me just the same. She would have been like, that's fine, it's your grandparent, they'll just, shrug things off. But I really wanted to be in a position that would have helped her. And so that was the motivation more so than anything. And then even my grandparents that were living, my dad's side, they were always pushing me, always motivating me, sending me money, things like that. And just knowing that, you're accomplishing your goal. Like if it's something that you wanted to do for a while and people know it and they support you. Even with that being said, when I was rotating on different rotations, I stayed with one of my friends' families for a month in his room. I stayed with one of my cousins for a month. I stayed with friends. So, I mean, this just huge support system of people who are like pushing for you and, rooting for you to be successful. I mean, it was just kind of my motivation. Yeah. So that was it.
My other
Awesome. Thank you.
financial struggles and burdens. Are you starving now? Are you homeless?
No, I'm not. I'm not starving. People always would tell me when I was, in residency and doing all these things. I was just like, "Whoa, how are you going to make money? Like these loans are crazy." That's another thing about podiatry. I mean, tuition. I mean, room and board is running between probably like 50 and 65 a year. 50 and 65,000 a year to be a podiatrist. So it wasn't cheap, especially if you wanted to, go to the MD or DO route. Like there are a bunch of public universities or tuition isn't that expensive. But for now that I'm out, I've been out for a year and some change and I'm doing fine, I do well. Me and my wife bought a house. I bought a car, been paying my loans. So I'm doing fine, man. I don't have any worries. I didn't stop paying my loans when, they were suspended for COVID. So, they'll be paid off. I think any physician can make a good living. I think there are people out there who just aren't motivated. It's not like, you can just say, hey, and just sit on your butt and be lazy. But if you're motivated and you're working and you put in the effort, you will no doubt make good money. You won't struggle. You'll be able to take care of your family as a podiatrist and obviously as any other specialty, and you'll be fine. You'll be perfectly fine.
Anybody has any other question before we let him go? Anyone? Well, I want to thank you, Dr. Lister, for coming and speaking and being able to spend some time with us. And again, he put his email in the chat, and anybody could email him and ask him more questions if you have them. Thank you again, and have a great night.